It began in healthy-looking pigs, months, perhaps years ago. A new coronavirus spread silently within herds. Gradually, farmers started getting sick. Infected people got a respiratory illness with symptoms ranging from mild flu-like signs to severe pneumonia. The sickest required intensive care. Many died. Experts agree unless it is quickly controlled, it could lead to a severe pandemic, an outbreak that circles the globe and affects people everywhere.
Europe, and that includes the United Kingdom, are not prepared together for this unbelievable threat which is coming now. And we are not able, or we have not organized ourselves to organize it in a way that we have everything what we need to treat these patients together. So it starts with ventilators, it starts with certain medication. So we have now some countries who have certain drugs and certain other things, some others they don't. So this is not coordinated, and this is a problem.
We're looking at pictures of the ventilators lined up. I've been challenging politicians here in the UK on the need to make these ventilators. I mean, we've got 4 weeks here. We need all hands to the pump to get the stuff ready that patients will need. Why is Europe dragging its heels in making these kind of things, this kind of essential equipment?
Yes, I think there are two problems. Number one, over the past several, probably 10 years, all over Europe, we're cutting down beds, and we also were cutting down intensive care beds. And suddenly, with a threat like this, we are all realizing, oh, we don't have enough high dependency or intensive care beds. That's one thing. The other thing is that the equipment we're talking about, probably if it would be distributed across Europe at the right time, it would have helped Italy. Once they're over, it could have been moved further on. But now everybody's buying equipment, and the companies who are producing it, they're waiting for the pieces to assemble.
So we're not manufacturing. We're not manufacturing it in Europe. Is that what you're saying?
Part of it. The parts of the ventilators are coming from China and other countries. And I know it, for example, from several companies in Germany who are producing these ventilators. They're waiting for pieces from China. That is a problem.
We've been talking about ventilators. What about medication? Because that has been some of the concerns, that some of the ingredients, as each country goes through their outbreak of the virus, that tendency not to want to then sell medications overseas.
Yes. A lot of our medication, especially antibiotics, which do not help for treating the virus, but most of the antibiotics are coming from India and from China. And you can imagine if there's a cut, if there's a shortage, if there's any other problem, we will suffer from that in Europe.
Can I ask you one final question? I was explaining to people that the strategy here in Britain now seems to be that we're moving to herd immunity. And maybe you're following that strategy in Germany. Have governments just decided it's pointless to stop it?
Yes, I think that's very clear. And we were talking also the European Society of Anesthesiology about it. You can't stop it. The only thing you can do is delay it, make it to slow down the whole process. That the actually intensive care medicine beds you have, that you slowly use them, but not at the same time. And I think that's at the moment the only way you can win the whole game.
Dr. Zakarowski in Frankfurt, thank you for that sobering assessment.
Called the RNA vaccine. With RNA and DNA, instead of putting that shape in, you put instructions in the code to make that shape.
And is promising is called the RNA vaccine. With RNA and DNA, instead of putting that shape in, you put instructions in the code to make that shape. You put instructions in the code to make that shape.
Safe and extremely well tolerated in all of our vaccinees.
216 people in all. The problem was the use of an HIV protein used in the molecular clamp technology. It was a small fragment of HIV, and scientists were aware of the risks of false positive results.
There was a theoretical risk of this, we thought, albeit a very low risk.
In a shock result, everyone who had the vaccine came up with the false positive.
The federal government was told on Monday, and jointly today with CSL, it was decided to halt the project.
We have known about caps-like viruses in animals and people for decades, but have not been successful at developing a licensed vaccine. And sure, there are new technologies that may help, but it's going to be difficult. I am not optimistic about.
Dr. Schwell, you've advocated for vitamin D as a potential way to prevent COVID-19 infections, to prevent severe COVID-19 infections. You've talked about this for a few months now, and over the past several months, the evidence continues to grow. There's more and more publications in peer-reviewed medical journals about the possible connection between vitamin D and COVID-19. So you've put together a presentation for us. Tell us about what your presentation is all about.
Yeah, thanks, Kyle. So we've been talking about vitamin D as a potential therapeutic agent for COVID-19 since March. And since that time, a lot of other people have become involved in looking at that agent as well. A number of research studies have been done. And the purpose of this is to sort of look at the evolution and the thinking of the use of vitamin D in COVID-19. So what we do is we look back even before COVID-19 and what was the evidence for vitamin D in acute chest infections, for instance, influenza, and what was the data there. And then we look at the epidemiological evidence for vitamin D as a therapeutic agent in COVID-19, and then finally moving along to actual cases, hospitalizations, and then we build up with that hierarchy of evidence with vitamin D and COVID-19 to randomize placebo-controlled trials, which of course are the gold standard for therapeutics.
Okay, so let's talk about vitamin D. The first thing you've got to understand is that vitamin D is not just a vitamin. Vitamin D is actually a hormone. And if you notice here by the structure, you'll see that it is a steroid hormone, which means it can go into the nucleus. It can go through membranes and make effective changes. And specifically, the vitamin D receptor is a member of this nuclear receptor steroid hormone superfamily. And so as you can see here, we have vitamin D going through the membrane and affecting a binding to the receptor, and then it actually goes into the nucleus where it can affect transcriptional change. This is really important. So this is not just some vitamin that you need to supplement with. This is actually a hormone that changes the way your cells in the body actually behave.
Is this idea unique to vitamin D, or does this happen with other vitamins? And in addition to that, what are some of the main differences between a vitamin and a hormone?
Good question. So, a vitamin is actually a shortened version of a vital amine. Vital meaning you need it to live, and an amine is a type of chemical compound. Vitamin D is not even an amine. Of course, it's vital, but it's not as if you need a certain amount of this substance to just keep the body going and doing what it needs to do. No, I mean, vitamin D is so much more complex than that. We used to think that vitamin D was just involved in calcium regulation, and that is certainly true. There's no question about that. But vitamin D is so much more than that. It's a fat-soluble vitamin, which means it can pass through membranes without any problem. It doesn't need to be regulated. It can bind with the receptor and go directly into the cellular.